Well, Mr. Paes, I just wanted to know about gallbladder polyps. We see them on ultrasound sometimes.
Yes,
what is the significance of them?
It's a good question. Gallbladder polyps occasionally reported on ultrasound, and you know, one wonders what you should do with them. I think if you get someone with gallbladder polyps, they should be referred electively, I mean, to outpatients, and leave the problem with the surgeons, really. But I personally just repeat the ultrasound in 6 months. Because it's very common finding, and I don't want to take everyone's gallbladder out because they got a polyp. There's no real evidence that polyps become malignant in the gallbladder as opposed to the colon. So, you know, they can be left. Are they causing symptoms? I doubt it. But if somebody's getting recurrent symptoms, they've got a gallbladder polyp, they know they've got a gallbladder polyp, it's in their head, you know, in the end we take the gallbladder out. But if I had a gallbladder polyp, I wouldn't have any go near a surgeon.
there is something about size, though, isn't there?
Size, yeah.
Yeah, if they're very big, I mean, that's why I scan them. If they're growing, then you know, that's different business. But if they're small polyps, I mean, these are very common finding ultrasound. You know, you can just refer them to secondary care in outpatients, and they can follow them up or make a decision.
I think the difficulty also comes when you start scanning the patients, looking for changes in size. And then it comes a point where you have to stop scanning them. And so the patient will ask, well, you know, it's 5 millimetres this year, and you scanned me again a year later, it's, say, 6 millimetres, and then what do I do next? Are you going to carry on scanning me? Because one of the points that Dr. Pitcher was alluding to as well is that the centimetre size cut-off in some institutions equates to a cholecystectomy. I don't know if you'd agree with that, Mr. Paes.
No, I'd agree with that. But you know, I've followed up many patients. They don't change in size.
Yeah.
And in fact, you know, the number of gallbladder cancers I've seen is small.
Sure.
And yes, we don't know if they come from the polyp or not. But the larger the polyp, the more worried you get.
Yeah.
But the small polyps, I think, which is what most of the scans show, I don't think needs anything urgent done about. But they should be referred on, because a patient won't ever be happy until they've, you know, had someone say, I'm not going to take it out, or I am going to take your gallbladder out.
Is there a role for using CA125 as a sort of screening, reassuring sort of test in these patients?
Well, the CA125 isn't really useful in bowel cancer screening at all. In fact, at Imperial College, if you request a CA125, a second screen comes up that asks you why you're asking for it. And unless it's specifically for ovarian or gynae-related problems, then they tend to not allow us to do it. So I don't think it's particularly useful. The CEA, however, is potentially of more utility. But again, I don't think there's any evidence that you use the CEA blood test, which stands for carcinoembryonic antigen, in a patient who you are suspicious of cancer of the bowel. You wouldn't use a CEA as a screening test. You might use a CEA in the blood as a measure of response to treatment, and perhaps after the patient has had her cancer treated, a rising CEA is a little bit worrying because it suggests there might be recurrence, but that's probably where you would use that blood test.
Can I just say something there?
Yes, please,
It's difficult. Did the government give some guidelines to GPs to screen women with abdo symptoms with the CA125? I mean, I don't know what you think, Owen, but I was always taught that these tumour markers are of no value in diagnosis. And certainly, given that a lot of people or women are going to be presenting with non-specific functional type symptoms, you know, a CA125 in my book is not a useful examination. If you really want to reassure a woman, I would have thought probably doing a transvaginal or a transabdominal ultrasound scan is going to be of more value than a CA125. You know, a negative CA125 is not going to reassure you in a symptomatic patient that there's not something going on. So I never send them off unless we found a malignancy and we're trying to track down where it's come from, the unknown primary.
Yes, questions?
I've got 3 questions regarding the 2-week pathway. The first one is, when you have a patient with lower GI symptoms, you refer them. What's happened in the past, like 12 months or so, I work in Ealing, but we use Northwest London. Patients gets a CT virtual colonoscopy, And if they don't find anything major, the patient is just then discharged back to the GP without seeing the consultant. And I don't think we get a clinic letter, we just get the CT report sent to us down the links. That's the first question. Second question is, sometimes we have patients with upper and lower GI symptoms with a bit of weight loss, anemia and change bowel habit or whatever. Are we supposed to then do 2 referrals if we want to top and tail doing, or will one referral, say a lower GI or an upper GI, cover both? The reason I ask is we had one patient who was referred with these symptoms on the colorectal route. That was fine, only to be then referred back on the upper GI and found to have stomach cancer, and they subsequently died. And the third question is with regards to a patient who's attending an NHS outpatient clinic. If they have red flags, what we're seeing now in the last 12 months is the patient's being sent back to the GP, which sometimes they don't come back, for us to then refer them under the 2-week rule. Because in the past, consultants were allowed to refer them under the 2-week pathway internally. So those, sorry,
no, sure.
3 questions.
Right. Robin? Yep.
Can I just, that's a fantastic lot of questions, because I think it goes to the very heart of it. I'll just say at the outset, like PSA, CEA, all, PSA, as you know, is the same kind of issue. But in terms of what you're alluding to, I think it's very important to recognize that if you take 100 patients over the age of 50 who come to you with change of bowel habit or abdominal bloating or abdominal pain, who don't have any anemia, for example, iron deficiency, and have not passed blood PR, there will only be 2 patients who will have cancer, okay? So all those patients who you're worried about over 50, change of bowel habit, we get like quite anxious about, and they fill up our thing. Only 2 of them will turn out to have cancer. Most of them will either be normal, have diverticular disease, IBS, or something along those lines. So you've hit the nail on the head. The idea of one-stop clinics is something that I think we should challenge. Not only because, as you say, you don't get an answer for you, the GP, who's actually asked for a specialist opinion, but if you take a chest pain clinic, if I may digress for a moment, if you get a negative ECG or stress ECG, which is in 90% of patients don't have ischemic heart disease, what's the cause of their chest pain? It's probably esophageal or chest wall or whatever. So, my feeling is that everybody should be seen within 2 weeks. You know what I mean? I think that's the only way that you can resolve this issue. Everybody, those people who don't get into the pathway, many of those patients have got cancer who never get seen until a year down the line because they don't present that way. So my view of your question is it's all about the way we're practicing at the moment, and that our aspiration should be that there's no 2-week pathway because everybody should be seen, maybe not in 2 weeks, but maybe in 4 weeks.
Whilst we can stand here and tell you that out of 100 patients with those symptoms, only 2 will have a cancer, you're the one sitting in front of the patient, and you're the ones that will look at the 100 and refer them because they have a change in bowel habit. And on an individual level, it becomes very hard. A lot of what you see presented to you is on population levels. And if you are there on an individual level, it's actually much more difficult to say to that patient, I'm not going to refer you. And clearly, so we have to have some arbitrary method by which we discriminate who, or you have to discriminate who you will and won't refer. Hence, you have these alarm symptoms. And if you look across the board, not just at GI, but other specialties, and you audit the pickup rate of cancers, which is after all what you're kind of referring patients on the 2-week pathways for, the discriminatory value of these so-called red flag symptoms is pitiful. I mean, again, to digress slightly, rectal bleeding is a useless discriminatory symptom. Dysphagia in somebody with reflux is a useless discriminatory symptom. So it becomes very difficult. It's interesting you comment about CT, the pneumocolon. So presumably, if I could take a show of hands, what proportion of you here have direct access to CTC in your local areas?
Oh, wow.
Yeah, for the 2-week pathway, yeah. But otherwise, you don't. But we are doing that as well at Imperial. But we happen to have a dedicated, interested group of individuals who run the CTC program. And when it's allied to bowel cancer screening as well, it's very easy within our unit to to cross-refer. Do you find, my colleagues on the panel there, what do you think about the inter-specialty referral business that we are no longer...
Well, I'll say a few things. I mean, this is the nitty-gritty of what we all do, isn't it? 2-week referral. Demand is just going up and up and up. Our patients are very informed. They'll often have an idea as to what they want when they come to see you. And what are the alternatives? You've got 2-week pathway. You've got standard referral to outpatients, which is being discouraged, or you've got choose and book, which is dysfunctional. So if they get choose and book, they'll get an appointment within 12 weeks, but that's to see a consultant who may just say, well, they need a gastroscopy or they need a CT virtual colonoscopy. So I rather think that the pathways need to be changed. They need to be radically changed. They need to be user-friendly to you in an expeditious manner. I think that we've heard about the potential dangers of colonoscopy, and I think you've all been familiar in the past with open access gastroscopy. The risks are less. Colonoscopy, you've got a cross-section of patients with fitness, whether they're on anticoagulants, the bowel prep, whether it's going to upset their kidneys. So open access colonoscopy has not been offered so much. But now with virtual colonoscopy, I rather think if you've got a patient with bowel symptoms, if you don't think it's cancer, the problem is if you don't think it's cancer, you've then got a problem there. You're going to refer them to the quickest way that patient's going to get sorted out, which will be 2-week wait. So we see the other way. We see that 2-week wait is overburdened with benign disease. So I rather think it's got to be refined a great deal. There's got to be better communication between all of us, and there's no need to refer patients in a traditional way. In the future, I'm sure you'll probably agree. I think we should be emailing each other, or a team of consultants should be able to give you an opinion down an email rapidly to help sort out the best way to use the pathways at your disposal. And coming back to cross specialty problems, if you've got iron deficiency anemia, if it's a postmenopausal woman or a male of any age, they need both their upper and lower GI tract investigating. So your case there, and this is of the colon being examined, not the stomach, this is a failure of the local hospital, and that's, in my mind, that's a negligent problem, or a communication error, or maybe the form has got lost. It's difficult to know, but so there's got to be some secure way within the institution you're referring to. If you've got a normal OGD, the colon must not be forgotten. But the referral pro formas that you send in, which were designed by the Department of Health about 10 years or so ago, they're fairly blunt instruments. They haven't been refined. And then the other thing is, what happens then if you do your CT virtual colonoscopy and you find these lung nodules? I mean, you'll be plagued with these patients. Okay, and then they then get referred to the lung MDT, and the whole thing goes on and on and on. The problem with the imaging is so good, you're going to find these incidental findings. Okay, one of your colleagues at Hillingdon Hospital calls these things a little, the incidental finding, which is a benign, totally benign. They call them a vomit, and then the patient is a victim of medical imaging technology. MDTs are full of those, and your patients will be full of those, and we've got to try and rationalise how these patients get handled rather than sending them from specialist to specialist or back to you. It's a huge problem now. I don't know if you agree with that.
Can I make a point?
Yes,
I think also the way that you pay us should change. To be quite honest, I'm not saying you, but the CCGs. I think you should only pay us for the solution of a problem. I don't think that you should pay us for the consultation or for the test. The quality of what you get back should be what the taxpayer is paying for in essence. So I think that until we change the way that you go and purchase from your provider by saying that chest pain or that abdominal symptom, I will pay you for sure, but I want you to get as close to a diagnosis as possible. If I'm not happy that you've gone that whole route, why should I pay you?
So what was the answer to the question about if the patient's got the upper and lower, do we do 2 referrals or 1 referral, and which one?
If it's iron deficiency, it should be 1 referral, and the hospital, in my mind, the hospital should then sort that out.
But that's a failure of I have to say my view is that is a failure of the doctor taking that history at the hospital. And, you know, if that person is just concentrating on tenesmus and a bit of rectal bleeding and not taking a proper history, and one of the things that Max was talking about is the need to take a proper history, and that's a failing of a doctor at the other end to not take that history, I'm afraid. And we have a similar thing, you know, if a patient comes to clinic and they've been seen in other areas, and let's say had other tests, and let's say they've had a breast lump that's had an FNA done on it, and they happen to turn up in your clinic, and you are seeing them from a GI perspective, but you're sharing the same screen, and you can access their results. Now, what do? If you see that that FNA is positive, do you wait for them to come back to the breast clinic, or how do you know that that FNA has been picked up and someone's going to act on it? You know, there's a lot of these issues, and we've certainly come foul of people reporting scans and things without relaying the result back to the referring clinician to say, look, you better act on this, you better get this patient into clinic or whatever. So there is a real fall down and a break in communication, as Max says.
Just one other point there. There is a responsibility on the referrer to make sure that that is iron deficiency. The problem is, I would say that, you know, say 70% of the time we referred an iron deficiency anemia, you know, you've got a hemoglobin of 10 maybe, but there are no hematinics have ever been done. You know, then that makes it difficult, because then should we be putting patients down the pathway without that evidence? You know, if you've got an iron deficiency anemia, they need an OGD, duodenal biopsies, Helicobacter test, and then they need a colon examination. Whether it's optical or virtual remains to be seen. But the interesting thing is that there is data out there for the normochromic, normocytic anemias, which are very common, you know, the so-called anemia of chronic disorder. If you're then going to choose what you're going to do with an indeterminate ferritin maybe of about 30, you're going to get much more utility out of doing a CT virtual colonoscopy, as Professor Epstein said, from picking up that chronic disorder there, such as, you know, the kidney cancer or the pelvic mass, which has not been picked up. But I think the patients do need a hematinic profile if you've got anemia, and probably also need a myeloma screen. But patients present in very difficult ways to 2-week wait. I mean, one patient I saw, we'd had all these tests, and this is the failure. If we don't talk to our patients, okay, they're just handled by direct tests, you'll miss things out. I remember one patient came to see me, she'd had all the tests, and I said, so what's the problem? I noted that she had an ESR of 110, and she says to me, well, it's funny, doctor, you know, every time I chew, I get this terrible pain in my jaw. She had temporal arteritis, and, you know, this is the problem. If the wrong patient is on that pathway, or on a GI pathway, you've got to see the whole patient. You've got to take the wide view.
See the whole picture.